who are with us in person and also those of you who are participating virtually, we're very excited to move forward with the Delivering Value Series Symposium this morning on optimizing on-site and near-site clinics. And first of all, I would like to thank all of you for taking time out of your incredibly busy days to be with us. And we are incredibly excited about the opportunity with this new product offering between the Business Healthcare Group and Symposium. And as many of you know, this is a direct result of the BHCG GNS Physician Value Study and what we've been able to do in advancing the deliverables from that study. So, and when you look at the partnership between the Business Healthcare Group and Symposium has been instrumental in moving this forward for the business community. And I don't look at this as being for the Business Healthcare Group. I look at it as being for the business community, and just as importantly for all stakeholders within the state of Wisconsin. So that includes our member employers, employers who are not our members, our health system and provider group partners, Symposium, and other stakeholders. And when you look at the mission of the Business Healthcare Group, we strive to be a good corporate citizen for the state of Wisconsin and endeavor to have what we are moving forward benefit all stakeholders. So for those of you who are participating virtually, you will have the opportunity to enter questions into the questions box that you're going to see on the screen. And we would really like to have this be more of a conversation than a presentation. And you'll see what I mean by that when I go through the agenda this morning. But again, please participate because if you have the question, there's absolutely no question that there will be others who have that same question. So with that, Jolene, can you advance to the next slide? Okay. Okay, the agenda this morning, my opening remarks, and then we're going to have Dave Ostendorf, who's the strategic consultant for the Business Healthcare Group, and he's also the chief actuary for Symposium, providing a general overview of this opportunity and the utilization of data, right? And then Jihei Tak was going to talk about on-site, near-site clinic optimization. And Jihei is a general manager or market manager with Symposium. And then we'll have two panelists from providing a health systems perspective. The first is Dr. Ashok Rai, who is a physician, and he's also the president and CEO of Prevea Health. And we view Prevea truly to be a partner, not only with the Business Healthcare Group, but also with Symposium. And then Donna Owens, who's the vice president of the Wisconsin Employer Solutions for Ascension, is also going to be part of that panel. And again, we value the partnership that we have in place with Ascension. And it's beneficial, again, we believe, to all stakeholders. In addition to that, then we will have another panel, and that panel is going to be Janet Lucas-Taylor, who is going to provide an employer perspective. Janet is the Senior Director of Employee Benefits at Northwestern Mutual, and Janet has a partnership in place with Premise, who operates her on-site clinic. And then finally, all of the panelists will come back up, and we'll have all four of the panelists available for questions together, and then I'll have some closing comments. Any questions from those of you in the room with the agenda? If not, Dave, thank you.
Thanks, Jeff, and good morning, everybody. When you think about the whole opportunity with Onsite and Nearsite, a lot of it has to be put into the context of what we're trying to achieve relative to the continuous improvement that we need in the healthcare world. Many of you have heard the Business Healthcare Group's perspective on where health really needs to evolve all the way through the both patient and the physician side of healthcare. Many of you have seen this graphic before, but it is particularly relevant as we talk about Onsite and Nearsite. We have developed a high performance model that is a solution in this marketplace that we think actually has a great deal of promise and can be used in other marketplaces as they continue to develop. One of the things that we have seen is that Wisconsin has the opportunity to lead in some of these real significant opportunities. The model itself says people get their best care when they have a strong relationship with a primary care physician and a primary care team. And we think that's incredibly important. And it really needs to start there, and people need to start their care at that level. That's one of the things that a lot of the kind of emerging data has said, that people struggle with making healthcare decisions if they don't have someone who helps guide them through, someone who has their best interest and knows them. So that relationship is important. At the same time, we as employers can come forward and say, we can put things into our plan design that encourage people to do just that, to create that primary care relationship, to live that primary care relationship, to actually both have a primary care physician and listen to that person. Those things are important, and we can do that with incentives through plan design that really make it come alive. When we do that, we are delivering to the primary care physicians a member who is well engaged, one who has a real incentive to work with them. That's important. And we think we're answering a lot of the asks that PCPs have had relative to being able to do their best work. We also need them to be fully now accountable for that patient and for the management of the patient. And finally, as we talk about paying within this system, we need to recognize at the end of the day, we are moving away from payments for pure transactions and for the 7-minute office visits and for the services that are provided, and much more into a value-based world where we can look at payment for outcomes and really change the way that people are rewarded for giving the best care to their people. That's the model we've created relative to the high performance model in BHCG. I think you'll see a bunch of those things come alive as we talk about the Onsites and Nearsites. One of the reasons that we really went down this path is looking at the results of the BHCG GNS Physician Value Study, and just some quick numbers. And as Jeff noted, I'm an actuary, so I have to have at least one slide of numbers. So this is it. But the simple message of the study was, as you looked at the variability within the Wisconsin marketplace, and this is data from the Wisconsin Health Information Organization, so the state's all-payer claim database, so this is the state of Wisconsin. What it said is, if you look at the performance of the physicians who are in the top half relative to cost efficiency versus those who are in the bottom half, and we could either have our patients seen by those in the top half or get the performance of the bottom half to move up to the top half, we could save 40% of the cost of care, of the episodes of care that are managed by PCPs. An incredibly important statistic. We also saw a fair amount of variability in the specialty side. And we looked at 10 large specialty procedures. And so there's additional savings that can go along with redirecting towards the higher value specialists. So if we can get that combination of PCPs performing at a high level, referring to higher value specialists, we've got a chance to save a quarter in healthcare. This is not a price negotiation issue. This is a resource utilization issue. This is the best practice of medicine, to be able to get people back to their optimal health as quickly as possible with the least amount of resources possible. There's a real opportunity here. So that really led us to the question of, so how do on-site and near-site clinics factor into this? How can we really make it come alive? And what we're really talking about is a world that changes. A lot of employers in the eastern Wisconsin marketplace, which has been a real hotbed of on-site and near-site clinics, set up those clinics with certain expectations. And in a lot of cases, those expectations for employees were, I've got a convenient, close by area, a site that's going to give me good acute care when I need it, when I have something that I need to be seen for immediately. It's essentially a convenient urgent care center. What we really want to do is transform that. into having the on-sites and near-sites be a real advanced practice primary care medical home. And a lot of the work that's being done within the health systems, and as you hear from both Purvey and Ascension, and as you hear from Janet relative to the work that the mutual health centers have done, have really been striving in that direction to create a different kind of relationship. At the same time, the clinics themselves have to transform from being just a provider of episodic care to being a true patient manager. And it takes capabilities, it takes investment, it takes resources. A lot of it takes a real mindset. And so as we look at ways to make that happen, it includes things like making investments around data and technology. It includes getting as much information as possible relative to things like the opportunity to refer to the higher value specialists. Those are data points that haven't necessarily been available in the past. We need to take advantage of the fact that they are available now. And finally, for the employers who have set up these clinics, it's really changing again from, well, we've got a clinic that's going to be a really efficient place for primary care, more cost effective than the general marketplace. It's a small silo, into a much broader conversation that says, let's look at our clinics relative to the appropriateness of their care, relative to how they manage our patients, relative to a bigger role, really, as we look at the future for our on-sites. It really takes the opportunity to say, if we look at our population today, and as we evaluated the BHUG member employers a few years back, we said, let's look at how many of the employees and their family members within our plans are quote unquote medically homeless. They don't have a PCP relationship. They don't have somebody they can rely on. And typically it was 20 to 40% of the people who didn't have that PCP relationship. It's a pretty big group of the medically homeless. We said the on-site clinic has a real opportunity to help us solve that issue, to create a relationship, have a proactive outreach to create that relationship, to really make it happen, to bring down our rate of medically homelessness. So those are important things that go into it. So strategically, what we're really looking at is a way to try to optimize a significant resource that employers have put a lot of time and investment into, that the on-site operators have really looked at as a way to kind of evolve their role, to create something for our people that really provides better healthcare. So all of that is strategically the overview of how we're looking at on-site clinics, but now you got to talk about how you can make it happen. So I'm going to turn it over to Jihei and let her talk about some of the operational pieces.
Networks we build have value to employers and can provide all the services that employees need while achieving healthcare, cost savings, but also achieve high quality outcomes. And so when we build our solutions and think about how we, build our technology and platform and configure it and offer it in a way that we integrate with such important key strategic part of our employer's benefit strategy, we thought about how we can use them to supercharge the near-site and on-site clinics that a lot of our employer clients in Wisconsin, use and are looking to use and better return on investment on. And as a person who also ran product for a large health plan, it's actually been a super challenging, but also very rewarding experience to have the opportunity to really build it into the health plan instead of thinking about an on-site or near-site clinic operating separate from the health plan. And I think that, there's a lot of capabilities that health plans or TPAs bring to the table because of the things that they do to administer the plan. Simple things like eligibility, benefits, and how we already have all the information, so we can help employers kind of, do the integrations and kind of send the data, receive the data, without having the employers needing to do the legwork that they've been doing on their own. Also, on the employee and member side, we have the ability to make it feel like part of the plan, not a separate or an additional offering. And so that's kind of a big capability that we wanted to deploy to help employers really maximize the value of the investments that they are making in the on-site and near-site clinics. The second thing is, the core of the high performance health plan model, which is helping PCPs and physician staff at on-site and near-site clinics understand who they're responsible for and which patients are engaged and not engaged, and drive engagement through incentives, financial incentives to the employees, but also communicating them consistently and promoting it in ways that where they typically receive information about their health plan. And third, as Dave alluded to, PCP relationship is really important, but we also know that it's important to direct members to appropriate care at the right time, in the right setting, to the right specialist when they do need downstream care. And because again, we've built relationships with providers in the Wisconsin, area and have a network, we're able to, help on-site and near-site clinics really drive and steer towards a high-performing specialist within the network. And I think that has the opportunity to bring tremendous value to the employers. And the last piece is really around kind of the data that's collected, purely because we're a health plan. We administer, we adjudicate claims. We have claims data. We have eligibility data. We have pre-auth data. And all of those things could have value beyond administrative purposes. It could help to drive, engagement before there is a claim event. It could help drive, fuel algorithms for, risk stratification. And so we really wanted to make sure that we are, using our technology and kind of our capabilities to share that data that really belongs to the employer with the partners that they choose to share with in a way that helps to drive greater value for the employers. So that's kind of the way that we thought about how we kind of build our solution and offer our health plan capabilities to integrate near-site and on-site clinics into the health plan model. I will go to the next slide. The hardest part is the slide. So, we thought about what's kind of the best thing to talk about in terms of what does this look like in real life, and I'm sure you will hear from others, but wanted to share some of the things that I thought were some of the best practices that we learned through kind of deploying this capability with our early adopter client, Janet. And so, the first thing is really aligning the financial incentives with the overall clinic strategy and the benefit strategy of the employer. And in this case, right, it's making sure that employees have relationships, have an established and working relationship with the PCP, someone who's guiding their care, and that there's no financial barrier to accessing that care, that we're removing any hurdles to getting that care, but also encouraging the use of all the services that are available there. And that when there is, downstream care that is required, there is a mechanism by which members are incented to go back and actually seek advice from the PCP that they're working with. And that's all around kind of the plan design and the financial incentives, and that's how presented to the employee. The second thing is about tailoring the communications to employees and members around that strategy in a way that resonates with them, clearly articulating what is the value that the employer, the benefits team is looking to offer to their employees, and all the assets that they typically use to communicate benefit information, whether it's at open enrollment or when it is that they receive their first health plan information or any kind of ongoing reminders. It's always front and center so that they're reminded of this important benefit that they have. And we're here sharing screenshots from the member app that members would use if they were a Symposium member, but also it's really any digital asset or any other, doesn't even have to be digital, right? If you have banners, whatever the marketing channels you have with your employees, the ability to kind of have a comprehensive marketing strategy and communicating to the members is one of the best practice lessons that I think we've learned through this process. The second best practice that we've learned is that it's really important for the clinic PCPs and the physicians to know who they're responsible for, and that it's both a commitment from the employee and the member and the staff and the PCPs within the clinic. And this is just the way that we've, done it within the plan, and would love to hear kind of perspectives from others on, other ways to do this. But we, enable the members to self-select a PCP within our app. They could also call too. And by that, they're kind of committing to working with their PCP while they're using the health plan. And we're also able to surface to the clinic, who have selected a PCP and who haven't. They can outreach in a personalized way to, encourage them to select a PCP or schedule an appointment depending on where they are in their healthcare journey. And we can also continue to send reminders or assign PCPs if they, choose not to choose a PCP, 90 days into the plan. And we can kind of drive more personalized touch points from there from the clinic PCPs and staff. So really having a way to make the commitment across the parties, communicate, who's responsible for which person and individual, and ensuring that there is continued engagement is something that we've learned to be really important. And I won't steal Janet's thunder, but I think the results really kind of speak for itself with respect to, how much engagement and activation you could get from your employees when kind of you deploy the communication with the engagement strategy. The third piece is the third best practice that we learned is around actually using data to drive care to appropriate care settings and to the right individuals for the employee who may be needing additional specialty care. And this is a screenshot of our referral portal. And this is where the PCPs or the referral coordinator or clinic staff could enter or extended member of the PCP team actually enter a referral for the member. And you can use different parameters, but we can build a medical neighborhood that is appropriate for the clinic, that considers kind of and search for the specialties and rank it by performance, and we can configure it in a way that that it's clear to the clinic PCPs and the physicians who the high performers are, so that we can help to drive care to the most appropriate care setting. So, with that, I will turn it over back to Dave.
Thanks, Jie. And I'm going to ask Dr. Rai and Donna to come up and go ahead and grab a seat, and we're going to and while we're working the technology, I'm just going to make a couple more comments. One of the things I think Jie was emphasizing in hers is that there is a collaborative process that has to happen to get to where we'd really like to be in terms of how the employer and the clinic work together to really drive some of these messages. And whether you are in a high performance health plan world like the Symposium world, or in a more traditional health plan world, there's still a lot of opportunities that go along with that. But I think we have sort of articulated a vision about where we think on-site and near sites really are going to go. So that's going to lead me to my first question. I'm going to ask Dr. Rai from a Prevea perspective. You've heard sort of where we think this world is going. Here's your chance to say we're doing the right thing or we're all wet. What do you think?
We've been doing on-site near-site care for 15 years. We have 45 on-site near-site clinics, 75 employers that partner with us. So I'd say what you presented here is a good start, and we believe in it. So when we set ours up originally, we wanted to make sure there was no difference, being a multi-specialty group, in the level of care and the technology and the type of care between an on-site clinic and any one of our primary care practices. So from having the EMR there, to having vaccine stock there, to having lab services drawn there and couriers taking them around, we wanted every one of our on-site near sites to be like a primary care clinic. Not like, but they're part of the same department. So there's not even two departments. They attend the primary care department meeting. And you talk about the cost plus model. That's how it all started, right? It was to reduce costs and sold enough to employers and use that line to reduce your costs, make access easier, and that will drive engagement. And what we found out over the last 15 years, it did, but it plateaus at a certain point. You get utilization at the clinic to go up, you get cost savings, but it kind of flattens out. You have a certain population that's engaged, and you have a certain population that, whether it's the dependents or the structure of the clinic, the hours of the clinic don't create full engagement. So what we've done over the last 3 years is to say, let's take that cost plus and offer that level of pricing in a compliant manner. So it took a 2-year legal battle to get a compliant manner, and offer that at every one of our clinics to our largest customers, or because we run our own health plan, customers of our health plan. So what I would say is all of those components that you're doing in on-site and near-site is great to drive, but they need to be driven at every level in primary care. So easiest way to do that is to expand that model well beyond the walls of that to get to that higher level of engagement. So we call it Prevea Partnered Health, and it's incorporated into our on-site and near-site. We actually started that when we had our on-site and near-site and realized the hours, we're not open on Saturday and Sunday, we're not open at 5:30, like the company closes at 5, so we offered an urgent care wraparound. So a discounted price so they could use our urgent cares. We have 15 or across the state that they could use. And we just kept evolving the model. And so I think this is a really good start. Some of the tools there I'm looking forward to, activating within our own site. But I think when we look at on-site and near-site and why it was born through convenience and cost plus savings model. But we can do that outside of the company environment. You just have to have the engaged the health partner to do that.
Don, I'm going to ask you, from the standpoint of someone who's been in this business for a while with a number of organizations and obviously having a key role with Ascension, what do you see as the biggest challenges in making these things happen that we've been talking about? What really is necessary to make it work?
Yeah, thank you, Dave, and good morning, everybody. So I want to talk a little bit about challenges, but I want to just build upon what Dr. Ray noted is the foundation for on-site clinics has been longstanding, right? It's a basis of access or expansion of access, which is always very interesting and appealing. It's a basis of quality care, and it's a basis of cost reduction. So those core elements are still inherent in what we're talking about today. So they have survived for a very long time. At the same time, when we think about employers' goals, the cost savings often come to the top of the list. And that becomes very transactional. So in return on investment calculations today, we're really looking at visit transactions. So how many primary care visits happened in the on-site, how many acute care, how many rehab visits, wellness visits, behavioral health visits, how many meds spent. And then there is a calculation between this is the cost of having done those in the on-site clinic compared to the cost of if they had happened in the traditional clinical setting or program setting. And the results are good. There is a return on investment for having an on-site clinic that potentially hasn't gone further than that. But what we're hearing about today and the data that we're seeing, and Gee, I loved when you sent an email yesterday and you talked about supercharging the on-site clinic. So when we talk about supercharging that on-site clinic or that strategy, it really is about something that I believe most on-site clinic providers have always been striving towards, and that we're talking about today, and that's that. So the more of that you get in the on-site clinic, the more patients you're truly managing, the more opportunity to take that transactional visit cost and make this into outcomes-based savings that can be documented and then shared back to the employer. So when we think about supercharge, we think about the next level. Absolutely, the discussion today about the engagement being at the root of that is where we should be talking. We also should be talking about data sharing. So thank you. The things that Symposium certainly is putting on the table. Ascension, of course, is already a partner with Symposium. We have had a very positive launch of using that in our primary care clients, our primary care clinics for individuals who are now insured by Symposium, as well as that high-value referral process. But the sharing of data is something that also, when we think about the next level, today in on-site clinics, we all share data to a data aggregator, sometimes to an insurer, and we don't necessarily get invited to the table, review that table, that data, to talk about that list of patients who could benefit. You know, we get wellness data, and we do outreach based on that, but we're not really getting the big picture data. So increasing the partners who are sitting at the table is a really intriguing thing when we think about supercharging. Now, are there challenges? To your question, Dave, there are challenges. And the number one is we're dealing with people. So employees and their families, and we're dealing with them making changes. So the very first change we're asking them to make is potentially a primary care relationship that has been longstanding, that they're not necessarily interested in changing. We also have to deal with potentially their lack of confidence in the on-site center. Maybe they don't see that as being a permanent fixture within their workplace. Maybe they aren't necessarily confident in a provider they haven't had a chance to visit, create a relationship with. We also are dealing with employees that might not be confident they're going to work for that employer forever, for their whole career, and we're asking them to make a change. So what was exciting to hear today in the presentation is a strategy that's different, and I also don't want to take Janet's thunder, because I think she's going to talk about how this really can work, and have individuals making that decision at the time of benefit enrollment, at the time of new employment, so that their PCP alignment is accurate from the beginning, aligning incentives with making those decisions. So when we talk about challenges, I think our first one is people. How are we going to communicate? How are we going to convince them? How are we going to get them into a new strategy and truly adopt that on-site clinic as their primary care provider? Once that's done, data is richer. The opportunity to react to data is different. The development of common goals, working together as a team, it all moves forward from there.
I'm going to actually follow up on something you were talking about, and Dr. Ralph, throw this over to you. The question of sort of the employer responsibility and the expectation of will it be there? You know, says an employer going into this better expect this is a long-term commitment. What's your experience been? Do employers get in and say, I'm going to look at it for a couple of years and get out? Have they stuck with it? What's your sense as to, you know, whether there is the appropriate stickiness to this whole process?
Oh, I can't think of one client that stopped their clinic in 15. So the stickiness is there, but we actually only do one-year contracts because we feel like we need to earn your business every year. That's just our internal philosophy. We feel like we need to earn it every year. And we try to do that. And through the level of engagement, like Donna was talking about, we've been able to do that. But I do believe that once an employer does start it, it's actually one of those hardest things to take away, right? Because if you've ever managed benefits for an organization, giving a benefit is great. Taking a benefit away, creates a little bit of gray hair. So it's one of those things, if you're going to make this investment, I think every employer that I've ever talked to, every CEO, CFO, benefits manager has always looked at this as a multi-year, decade-long or farther outreach. One of our largest clients actually committed that to us. Their demand is that we sign on for multi-years versus us.
And in that light, and Donna, you talked about ROI. One of the things I think the traditional models have done relatively poorly, as you noted, is really looking at what should be included in that R that goes over the I. From an Ascension standpoint, have you started to create a perspective on how to get and capture the data to be more holistic about helping organizations that are coming to you and saying, show me the ROI?
Got it. So yes, Dave. So it absolutely is something that I think not only we are, but everyone is dedicated to. I think for employers, there's a lot of comfort in the transactional visit direct ROI calculation because it's very quantifiable. So when we take the next step and we start to talk about productivity, about downstream savings, around better management, I think we're looking forward to better data and partners who can help us with that. But, EMRs can definitely be at the core of that. Some of the advancement of reporting that we see inherent in those systems is going to help. But yes, we're looking at every opportunity to prove the next level.
I've been, dominating the conversation so far, so let me see if there's any questions in the room for Dr. Ryan, for Donna, and I will also check to see if there's any questions that are coming in electronically. So any questions in the room from things that you've heard so far? A brave soul willing to jump in.
So one thing like that.
Yeah, I mean, the most expensive patient that you have is the one you're not seeing, right? And seeing a patient and engaging a patient are two very different definitions in healthcare. Some people have known that statewide. I've talked about my own healthcare issues. I went 10 years without a PCP visit, and nobody has more access to a PCP than the CEO of a health system. And how costly that 10 years was to me personally, and CFO will point out exactly how much it costs the company. And so we have to find, and I look forward to working with the Symposium team, a way to measure engagement. And we really don't have that. I mean, we can do the check the box. We have a couple companies that are starting to do this now, where part of their requirement for their benefits is filling out a form from their PCP that I had a visit, and that helps them with either their monthly cost or contribution, or they wipe out a month. And we've seen different benefit designs around that, and that's a great start. But from a statistical standpoint, we need to figure out a way to define engagement. Engagement isn't seeing that PCP, but actually making change driven by that PCP. And that doesn't exist really. I mean, there's no engagement score in healthcare. But we do need to figure that out, because like I said, the most expensive patient you have isn't the one that's coming to the on-site clinic that we're giving the exact same ROI calculation. We do our ROI calculations identical as the two organizations, because most do. And that's our famous ROI calculation, and it is savings. But then they don't understand why their costs are still going up. So they see savings in a category, in a cylinder here, but they also see expenses rising here because they're not engaging that other corridor, that other column there. And that's the most expensive patient, the one who's not coming in, or is coming in but not engaging. And I think that's why, I think we even have discussed, what's the way to get them to have an appointment. But there's a big difference between still a practicing physician and, as is my chief quality officer, Dr. Pritchard, in the room. There's a big difference when a patient comes to see us and actually when a patient engages with us. So I think we need to figure that out.
Sorry. So there is a question that came in from a virtual attendee, and this is a question for both of you. And what do you see as the opportunity for utilization of the data from the BHCG GNS study and also the physician value scorecards from WIO for the referrals to the high value specialists? Donna, would you like to go first?
Sure, I can go first. So I think it's a two-part question. So first of all, as a health system, the value of the study, the GNS study, as well as the WIO data, is that we now have a confirmation of which of our providers are already ranked the high value. In the Symposium system, only they can be designated as your PCP. So it also gives us a list of who didn't yet meet the mark. And then that's a piece of work for us to do as a health system to dedicate what is that next level any of our providers need to get to, be it our primary care providers or our specialists, to make certain that they are also on that list, meeting that mark, and are at that level that they're going to be able to affect us. Because I do believe when we talk about high value, we are talking about that combination of quality and cost. It's not just one or the other. It's who gets patients to a better status faster, with less cost attached to it, because they are that higher performing provider. So the second part is on the referring specialists, and I believe the answer is similar. Who is on our list, and how do we make certain that we stay diligent to those referrals that are going to that high performing specialist? If they aren't in our system, then we need to do the work to make certain our specialists are on those lists. And if they are not, then we need to make that appropriate referral to somebody who is.
I'd once again echo everything that Donna said. I think the scorecards and the data that we're getting is a good start once again. The biggest cost missing in those report cards is really site of service. If we're going to truly make a big dent in costs, we need significant site of service data and site of service transformation in the state of Wisconsin. Way too many things happen with a hospital charge that do not need a hospital charge. There's way too many procedures across all specialties. They're happening with a facility fee in a hospital that really should be done outside of one. So we've opened up our first multi-specialty ASC non-hospital base. It's a little easier when you're a group of doctors that partners with a hospital and not owned by one. So that's not easy for every group to swallow or to be able to do. But so I think the scorecard's a start. But when you really look at cost, yes, you can find differentials in quality and differentials in outcome. And you're going to have physicians argue that, because trust me, I have partners who will argue that every day. But the one thing you can't argue, and what has the largest delta, is site of service. So, like I said, it's a good start that we're getting that data, but the real data we need is that combined with site of service to make the real decision that's going to drive real value.
I'm going to bring up Janet, and I'll have you two stay here because we're just going to add to the panel to go. I want to add the employer perspective to this because Janet has, as she launched her high performance option 1122, she's lived through some of this transformation and what it actually looked like, and have lived through all of the opportunities to gain some of the additional value, as well as the opportunities to deal with the pain of doing something new. So I'm going to kind of give you the open-ended question, Janet, of how did it go and what would you tell other people?
All right. Well, maybe I'm just going to set the stage for those who don't know anything about the mutual health centers. Northwestern Mutual operates 3 mutual health centers, one downtown right across the street, one in our Franklin campus, and one in New York City. Our services are full primary care, for employees, spouses, and children, including infants aged 0 to up. We have a full-time behavioral health counselor on staff. We do labs on site, and we have physical therapy for all of our employees and their families. So we have been operating these clinics pretty full spectrum for a number of years. When we implemented the high performance plan, we actually saw the utilization and the attribution go up, we believe. But to everyone's point, it was really difficult for us to figure out who was attributed to the mutual health centers from a primary care perspective previously, right? So they might have come in, but they're also seeing a PCP in the community, which was surprisingly very common, right, for individuals, and not really kind of having that person be their guide. So we've seen increased attribution. We worked with Symposium for those that didn't activate and lived within a certain radius of our mutual health centers to auto attribute them to the mutual health centers and a PCP, and then partnered with our on-site clinic provider Premise to actively outreach to those individuals once they were attributed. So inviting them in, giving them a bio of the doctors, and inviting them in for kind of their well visit piece. So we've had very little noise related to that. Overall, those that are in the high performance plan, from a member perspective, we've had tremendous feedback about the convenience of using the mutual health center, how smooth this process has been in comparison to the community. And I think that's because the on-site clinic, we had such a opportunity to communicate directly with the clinical staff and our partner and really drive the behaviors from them that we wanted, made referrals easier out in the community throughout time. The other piece that Symposium's just allowed us to do, and it's going just fantastically, is in the system, our physicians and clinical staff can look at referrals that are expiring. So if I'm seeing a cardiologist as an example, and that referral is expiring, they can proactively look at that clinical record, assess whether or not they need to see the patient in person, whether or not they need to message that patient through the portal, or whether they can just extend that referral and make that process really seamless for the members so they don't have to do anything. There's no barrier to that ongoing specialty care, and that has been received by our employees and their families just amazingly, because it's easy, right? And that's what we want to do, is remove those barriers to care and really make it easy for our members.
So Janet, that sounds like real life ongoing patient management.
It is, yes. Yes.
You know, from when you think about, you know, where the mutual health centers have gone, obviously they've been around for a while. They had to accommodate certain levels of change, in particular around the specialty referral piece. They obviously had some specialty referral patterns that went along with relationships they had or people they knew. How heavy a lift was it to get them to move towards a more data-driven specialty referral process, and both to learn the technology side of it and to change the operating procedures that go along with it?
Really very easy. So the technology is very, very simple, right? Using the Symposium portal, we haven't had any issues with that, and the staff's been very open to it. You know, a little tongue in cheek, Dave, but for those that have on-site clinics, if you're an employer, you know that you have a tremendous amount of opportunity to make things happen, right? So it was not difficult for us to say, hey, you're going to use this portal, you're going to select the high-performing physicians, and we understand that you have some relationships in the community. And some of those may be high-performing physicians, but right now, we're giving you an extra piece of data, and that actually has been appreciated, right? And I think in a couple instances has been eye-opening. You know, when we talk to our physicians, and I'm sure other physicians will feel the same about this, they will say, we made referrals based on what we knew and the convenience and integration of the information that we were getting back at the clinic, right? So if they're sending someone for imaging, they want to make sure that something's coming back to the medical records, that they can get that patient seen timely. And so they were making judgments based on operational and convenience related pieces. And I'm sure some of that still happens, but now they have a list of quality metrics as well that they can look at and rely on. It's been very easy.
Let me stop again to there's questions from the audience, either here in person or virtually for Janet and from the employer perspective. Go ahead. Let me grab a mic here for you.
Is there any extension of your services beyond the on-site and near-site for like truly remote or like the hybrid workforce, so you can extend those capabilities to folks that aren't able to utilize the on-site and near-site clinics?
Great question. We're actually working on that. So we have implemented virtual primary care with Premise Health. That will be a focus for us in 2023, is really how can we utilize that sort of virtual kind of care aspect and having them integrate as well. But right now we're pretty locked to those that have access. But I would say when you think about the 8,000 employees that Northwestern Mutual has, over 6,000 of them, 7,000 are here in the Milwaukee area. So we're pretty lucky to have a pretty tight footprint.
Let me extend that question to Donna and Dr. Rai. I know that both of you made meaningful investments in the whole telemedicine virtual care world during the pandemic. To what extent have you been able to take your on-site and near-site and use those as a vehicle to really augment your virtual capabilities?
Yeah, the good news is we have been able to implement the virtual options in all of our on-sites and are tracking, excuse me, with about 10 to 15% of our visits are actually being done virtually. We've just extended that to also offer another level of service, which we're calling the hosted virtual visit. So those individuals who maybe aren't comfortable having that from home or would like to come into the clinic when maybe it's part-time staffed and there isn't a provider there, but we have support staff who can take their vitals, room them, put them through the same experience. They can now have that virtual visit, but there is a support person, a nurse, or a medical assistant who's there to help answer their questions. So yes, all in on the virtual care is a system, but we have been able to extend it to our on-site clinic.
Right.
Same exact experience. We've extended it in all the ways that Donna described, and also have a separate service, but associated with the on-site care, but you don't need to have an on-site clinic for it, for occupational medicine injuries. So basically you go into a room, you turn on a camera 24/7, there's an OCMED provider there for injury triage at that point, obviously keeping mod rates down, preventing ER visits, but that's a component, especially for those with on-site near-site clinic, then they have that care component associated right with it. But it's just, we continue to expand what we're doing in tele. We have an endocrinologist that's almost purely tele, where we do the hosted visit, and we have your endocrinology consults, almost like I said, on a monthly basis, but everything else is tele.
Sorry about that. I have a virtual question for all three of you. So are the physicians employed by the employer? Are they contracted? Both models. How do physicians learn of this opportunity? Janet
I'll
first.
speak, yes, to the physicians are not Northwestern Mutual employees. They're all employees of Premise Health. And although I would say for any employer who's out there, I would recommend if you're having an on-site clinic, make sure your contract allows you to keep the staff if you do change a vendor partner. We have done that. Our physicians have been with us for almost 15 years. So there's a lot of continuity of care for our individuals. And the opportunity, what do you mean by that?
How do physicians, and this is probably more appropriate to Dr. Rai and also to Donna. But I do have a follow-up for you, Janet, concerning the contracting initiative that you put into place to ensure the continuity, right, of care from those physicians. How many different operators did you do this through?
The mutual health centers had one previous vendor.
Yeah.
So there have been long-term partnerships with us, but we did maintain all the clinical staff when the move occurred.
Yes, what a very innovative move on the part of NML. So, Dr. Rai, so are the physicians employed by the employer? Are they contracted, both models? And how do physicians learn of this opportunity?
In our situation, we contract with the employer as Purveya. Our physicians are owners in Purveya. They own 50% of the common stock. So they're owners in the company, and we recruit to that opportunity. So we have an opportunity, our recruitment team is there, and they recruit to the opportunity.
And Donna?
Yeah, similar to what Dr. Rai noted, our providers are employed by Ascension, and they are part of our medical group. And again, if we have an opportunity for an on-site, that is presented through recruiting and also working with our on-site employer partner to make certain that during that interview vetting process that there is good fit for the organization.
Okay, and then this next question is for Dr. Rai and also Donna. It is clear you believe in the on-site model, and it is difficult for an employer to make the leap to implement an on-site clinic. So on the topic of ROI, do you provide any contractual guarantees for either financial savings or employee engagement, at least for the first year? And then I have a follow-up to that one.
We do. Probably for competitive reasons, I'm not going to completely explain that. I doubt Donna would either, but we do. I could just answer, we do.
So, and I would say it's a little bit situational. So we always want to talk to the employer about that. As health systems, I think we've had an opportunity to be a pretty low-cost on-site provider. So any management fee that's involved is usually pretty small. Are we willing to talk about performance guarantees always? What intrigues me is moving into a model like Symposium and the tools and a richness of data. Perhaps performance guarantees are aligned also with performance bonuses. So getting paid on value and actually outperforming expectations would be an opportunity, I think. And I would both be interested in.
So that is an incredible lead-in to the follow-up question. I could not ask for a better lead-in. To my previous question, do you share in the risk to help employers see that you are in it together for both of you? Donna?
Absolutely. I mean, we're totally dedicated to that partnership, to that active reporting, communication, because this is a partnership. You know, we can be the provider sitting in an on-site clinic, but if it hasn't been well communicated, if there haven't been incentives aligned, cost sensitivity to the use of the center versus getting into the traditional healthcare, where it really is a partnership. So we always want to talk about what we're sharing from goals, from responsibilities, and then also from rewards.
Like I mentioned before, we do assume some risk based on some performance guarantees, but a lot of the weight is on us. All the marketing weight, all the communication weight, all the design work on that. We handle that. But the employers are a partner, so they're, you know, fully engaged in that conversation. I'd say just the planning aspect of before launch can be up to 6 months, and that's, you know, not. And some people say, well, that takes that long to recruit. No, it actually takes that long sometimes to really, you know, figure out what your marketing plan is, figure out what your plan design is going to be to support this. Making sure both sets of legal counsel agree that that plan design is not going to put anybody in jail. You know, there are some complexities to that depending on what their overall benefit structure is like, high deductible versus not. So there's a lot of complexities, but yeah, we do assume some risk. But like Donna said, it doesn't work unless there's mutual engagement.
Janet? Are you able to address the
The risk question?
yeah.
We currently have performance guarantees in place. They are related to many metrics, including clinical and ROI metrics. We really firmly believe at NML that the quality aspects and the engagement of our employees within the mutual health centers really drive the savings. So we do focus on, right, the engagement and the care and making sure that our clinical metrics are above standard.
So let me actually take that topic a little bit farther because, especially since I have, two of our key health systems here, and I can see if I can get them to make commitments before, this audience. One of the things that we talk about in, performance guarantees traditionally has been, if you don't do this, we get something back as the employer, which is, sort of a one-sided guarantee. Let's flip that around. To what extent, as we look at the next generation, should we be paying our on-sites completely under a value-based model with expectations around the total cost of patient care, with you having the opportunity to share in those savings to the extent that we beat the savings or, substantially exceed where we want to go? And to what extent is that a model that you are willing to entertain sort of in the next generation of on-site near-site?
We own and run our own health plan, so that's that's the world we live in for a big chunk of our commercial market. Over 50, probably 60% of our Medicare patients are in a Medicare Advantage product where we have a similar arrangement there, and now we are a part of a larger ACO where we have this similar structure. Bottom line is, that's the world we now expect to live in. That's the infrastructure we've created 20 years ago when we spent money on Epic, and I really don't want to know how much we've spent since then. But all those investments were designed around value-based payment systems. So right now, obviously, we have a foot in each canoe. One in the value and one in the volume. But the more that moves over to value, the more that we get to give Dr. Pritchard to reinvest the value. So I think it's really important for every structure that we have with a payer right now to involve some sort of value conversation.
Donna, your thoughts?
Yeah, I would just note, boy, we'd love to learn more. So in our current system of on-sites, right, there is a cost to having staff allocated there. And because it's very transactional, that's how we get paid. So getting paid on value, but understanding that there is a panel of individuals who have chosen that on-site provider as their PCP opens up an entirely different discussion. So yes, let's learn more and see how we can get to a different situation based on data and based on that PCP alignment. So.
Great. Well, this has been a good session for me already, so I appreciate that. Jiha, I'm going to bring you up to join the others. And one of the interesting questions and one of the maybe historical anomalies that have gone on with on-sites and near-sites is from the health plan side. Claims administrators, insurers have often viewed on-sites and near-sites sort of as that thing over there that we put in the corner and we don't really want to engage with. You've had to live within a different world with Centivo. Can you comment, and I know that you've had, past experience with some of the traditional carriers. Can you comment on the why and, how it makes sense to move into this new world where the on-sites and near-sites are really part of the health plan as opposed to being off on the side?
I always like to start with the premise that a lot of times the way that things work in healthcare might actually not make a lot of sense. So I think it's important to think about what are the real drivers as to why employers chose to operate on-site and near-site clinics outside of the health plan. And again, this is just based on my experience, but the way that, large carriers have organized their businesses and run their businesses. And if you think about the margins of different lines of business, and kind of, if you think from that lens of, building what would be considered custom networks with providers and physicians who are not really part of your network, and trying to operationalize that within the, very structured way of running the business for scale, and not having thought about kind of how do you plug in these partners that employers bring to the table, it becomes, from a traditional health plan, operating model and business perspective, a really difficult thing to scale and make efficient. So from that lens, if you're asking me why did this happen, I don't think that it could make a lot of business sense within some of the constraints of the way that businesses have been built from a traditional healthcare perspective. And again, that's just my perspective. And then, if I think about what are the benefits of integrating that into a health plan, is that, again, kind of seeing from kind of what I would call kind of the traditional world into what we're looking to achieve with BCG and employers generally at Symposium, is that there are opportunities to integrate deeply with partners that will add value to the health plan and make it into one experience for members. I think that's one. I think the second thing, I think a lot of folks have alluded to, this is just the beginning, right? Like, what does engagement really mean? And what does it really mean to get paid on value? What does data transparency mean? I think it's really hard to achieve that when things are disconnected. Like Janet spoke about, who really owns this patient if my employees are seeing this doctor in the community and this PCP physician. And so then, right, like that makes that really difficult. And then paying for value, which is really data driven. If the clinics are not at the table and doesn't have access to the same data as others, how do you even begin the discussion around value? And so I think those are some of the reasons why, from an employer lens, it would make sense to integrate into the health plan. That's just my perspective.
Yeah, and I'm just going to add to that. For us, we had been asking, Northwestern Mutual had been asking the health plans to put the mutual health center staff and physicians in the network for a number of years, and that wasn't something that, our traditional health plans were excited about. For us, what it does is it increases the chances of engagement as well, right? And it does make the employee see the mutual health centers as just part of their healthcare network. It has been extremely effective to have those physicians pop up when, think about a new hire who may not actually really understand that we have a mutual health center, but they need a PCP. So they go out, and the first thing that pops up, right, is the mutual health center. And they are, we all know, like, we're not going to scroll through 20 pages of primary care physicians. We're going to select probably somebody from the top. And so that has helped us. And again, really helped the physicians at the mutual health center feel like they're connected to the community, right? And have a different level of information that can benefit their patients through the data that's being provided.
I'm going to ask one of the, tough questions that always pops up, and having a panel where we have two health systems who are providers of on-site centers, and then Janet, who's using an independent non-system connected provider. The cynics say if you're part of a health system and providing the on-site, you're just doing it to get more volume into your system. And so I'm going to have the two of you address that potentially that potential critique, as well as talk about the advantages of having it within the system. And Janet, I'm going to ask you the same thing on the flip side. Having an independent provider without a connection to the health system, where have you seen that from a pros and cons standpoint? So let me start with the two health system folks. Why aren't you doing this just to get more volume? Why isn't this just your play to get as many patients as possible?
Well, inherently, we're a multi-specialty group, so we believe in coordination of care between specialists and primary care, and the best way to do that is make sure it's within the same group and partner sharing the same EMR, all of it flowing well together, and making sure you're hiring and monitoring quality for everybody to make sure they're delivering value and using those metrics. So it isn't about just driving volume to us because kick us out in a year. It's pretty obvious that our model doesn't work if we self-refer just to drive costs up. Unless your costs are going down and you're seeing value, we're out. So we have a lot of incentive to stay, which means we have to be providing value, which means our specialty providers have to be of value. And we believe in coordinated care. Discoordinated care creates, I can give you example after example of where it creates problems and expense or bad outcomes. And, I'm not saying that we're perfect, but at the end of the day, we have to keep those contracts by providing value.
Johnny or Alexandra?
So I have worn both hats, and I have sold both systems. So I would say that some of the differentiation between health system providing your on-site and an independent providing your on-site has started to get blurry. So if we looked years ago when indeed health systems may have gotten into it and had primary care providers in their own system say that looks like it competes with me, you should do acute care in the on-site, and then that looked like it was feeding primary care. I think there were probably things that were done by the health system for good reasons. They weren't going to get bad care with the primary care provider, but it started to look like it was a funnel, right? A health system has this on-site to provide, yes, some access to good care, but it seems to be funneling it to primary care and potentially to specialists. That is no longer the case. I don't know a health system at least in Wisconsin, who hasn't taken the approach now of primary care is absolutely one of the services that are being provided right at the on-site clinic. And they figured that out with their primary care providers and their medical clinics to understand this isn't a competing service. We are one system. And now we've been able to extend the good things into the world of the on-site as well. The other thing I think is different today is a health system, we definitely could talk about that integration of the medical record. We had all of the parties, we were all on the same page on the system. I would say that's gotten a little blurry in the other direction because with platforms like Epic, independents can also have access to some of that information. So some things have it's evolved. And there's potentially still some impression that the health system isn't a valid, absolutely dedicated primary care on-site provider, but it's evolved. The difference, I would agree with Dr. Fry, is we have the whole house in the independents when indeed they're providing great primary care. I don't want to say that they're not dedicated to all the same things that we're dedicated to with on-sites. Again, I wore that hat. They have to go make all those relationships in order to get diagnostics, in order to get the specialty referrals. This is a great tool that'll help with that as well. We own and control the rest of that. We can have those internal discussions. We can make those referrals in just a different way. Those processes are there. They're already part of the same team.
Janet, your perspective?
Yeah, I think that the premise team is fully on Epic, so we, don't have a true integration issue with specialty information. I think historically, maybe the biggest challenge was creating those relationships within the community. And as I said earlier, it's where they tended to build them. That's where they referred. Now they can use data, which I think is much more effective for us. The other thing I would add, and I've just been talking to the health systems since this partnership and the work with the BHCG, And what I've noted is a vast desire to partner with Premise Health and Northwestern Mutual in areas of specialty care or imaging or pilot programs, et cetera. So I don't know that there's that much of a challenge for us with the mutual health centers.
Other questions in the audience? And Jeff, I know that you're going to check, see if there's any virtual questions, but any questions in the room?
I'm curious if, by extension, outside of your own practice, do you partner with any third-party or point solutions to augment those capabilities for like chronic disease management, mental health, substance abuse disorder, anything like that?
I'll take that since we do run our own health plan. We do. Actually, we are about to launch, I don't know, but we just agreed on to look at, to augment our internal chronic disease management with a platform that would help us in a more robust way, allow our chronic disease managers to double or triple their panel size. So we're augmenting that with an outside vendor. On the mental health and AODA side, because we operate such a large center, we actually sell that service to others, but we do that internally. I think those are the 2 points that you talked about, and probably the most common integration point, like I said earlier, is in that occupational medicine, where we also supply that. But the areas that we do partner outside, we're looking every day for better chronic disease management tools, especially that can use our data to help our care coordinators, and we are launching that this year.
I would actually, I'm just going to add to just a bit of an employer perspective. I think it's really important to integrate any point solutions that you might have. So we worked hand in hand with our on-site providers as well as our point solutions to have things like Livongo diabetic meters on site so that our providers can actually sit down with a patient, bring the chronic condition nurse in, and say, hey, here's how you use this. Here's what we want to see. Here's what you're looking for, and making it real. The other piece that the group mentioned earlier was, how do you get people to engage? And we were just talking about that. We are looking at incenting things like referrals that are made from our physicians or our physical therapists to our on-site fitness facility and saying, hey, like, here's the script, take it over there. We'll incent you for following through, right? We'll incent you as a patient for better outcomes. Help us help you.
So a follow-up for Dr. Rai from someone participating virtually. And I do have to smile about the part of their question, and that is, although I'm not an advocate for this, do your clinic models allow for treatment of work comp claims?
Yeah, we gotta make sure I legally answer that. We do see some work comp in the on-site clinics. It's structured contractually a little different, and obviously in the state of Wisconsin, choice is mandated for the employee, so they aren't mandatorily sent that way. But if they do present for an injury, we can manage it in that way, because we use Epic for primary and specialty care, SysDoc for occupational medicine. It does get a little blurry, but we have a way to manage that internally.
Donna, same question.
And same answer. I would say there is a sensitivity, though, if we are seeing a work-related claim, that we're billing that to work comp, counting those hours that potentially we're using on that to take that off of the time we're billed to the client, because we don't want to double bill.
Yes.
But,
Okay, thank you. Dave, the next question is for you. And this goes to data and, once again, the BHCG GNS study and then the physician value scorecards from WIO. So I'm not understanding the offering from BHCG incentivo for the employers with on-site and near-site clinics. Can you provide some additional insight?
Well, first, I wasn't supposed to work today. I was just supposed to answer questions. But I think the way to think about it is really there are three different kinds of employers. There's the employers who are already ready to move down the path of putting in the high performance model that Symposium administers on behalf of the BHEG. So someone like Janet, they're using the data from the specialty referral side is sort of an obvious part of that integration. And that one, we sort of talked about. The second group of employers are those that are thinking about moving down this path, aren't yet ready to make the step towards that, and are saying, can you get my on-site, near-site kind of moving ahead of where I am as the employer? So can you start this process this year that says, let's use things like the referral portal, let's use things like the GNS data to change our specialty referral patterns, let's pick up some of the lessons learned that Jihei talked about, and start down that process with the idea that this is a incremental step towards adopting the high performance model. And when you're in marketplaces within the state where Symposium has built out the network, we can pick up the elements that go into things like the network directory and who's in network and all those type of things. The third group of employers are those who are saying, I'm not likely to go down the high performance model, at least for a while, but can I still use the data? And part of that becomes a question of how far you want to go with your on-site. That's where it becomes a stretch from the Symposium side to say we can support you with for example, an employer in Stevens Point, which is not a geographic area where we have the network built out. We'd have to actually import all the information around what the network looks like. But the data that's in the physician value study is available to the on-site operators to actually bring it in house for them and to start use that to create their own medical neighborhood. So that is a direct opportunity to go and get the physician value scorecards from WIO and to start to build it in there. From the Symposium side, we can talk about how we might be able to support that a bit on a one-off basis. But I think you have to look at, as an employer, which of those three buckets you fit into as you're thinking about the best way to access this. Obviously, in the first two buckets, we're talking about something that says, let's sooner rather than later get set up with the Symposium technology relative to the referral portals, use that to make the specialty data really easy to use, as well as start to pick up some of the learnings that we've talked about.
Any additional questions from those of you in the room for any of the panels? Yes.
I think it was Dr. Rye that said in 15 years you haven't had one client terminate or cancel. But I bet over 15 years, if you had to, you could rank the most successful to maybe the least successful, if you had to. Won't ask you to do that, but could you comment on what makes someone the most successful? Like, what are the challenges that some push through? How do you become best in class with offering a clinic?
We had one client actually move to a different provider from us in that 15 period, but they kept the on-site clinics. I think that was the original question. How I would say the most successful ones are the ones who really, as a leadership team from the C-suite down, are really engaged in the success and the communication of the success of their clinic. People who truly structure it as a benefit and understand the rewards. So I'd say there's, certain C-suite members and clinics that are doing okay. They're like, yeah, it's a benefit we offer. It's over there. It's off to the side. And there are those who are truly engaged. And this is part of our health strategy. And those are where we probably see the best. The ones who are always at the table with us saying, what other services can we bring in? Can we bring in care management on site? Can we bring in X, Y, or Z on site? Just like Ascension, we do PT, we do behavioral care, we do care management or chronic disease management, care managers that are actually off-site but integrating with the on-site. Those are the most successful. Those are the ones where I think you get the largest stickiness because they're getting ROI more than just that transactional ROI. They're starting to see over trends, because it doesn't happen overnight, really where the value is, and they're starting to see their overall spend trends adjusted for price increases going down.
Any additional questions from those of you in the room? I know we don't have any additional questions from those attending virtually. If not, and we're actually right at time, which is a miracle. So first of all, I would like to thank our presenters this morning, Dr. Rai, Donna, Janet, Jihei. Immense gratitude for all four of you taking the time to prepare and also to join us this morning. Thank you very much. And I would also like to thank everyone who has joined us, either in person or virtually. And there will be a recording and an executive summary of this that will be available that we will send to all of you. And so this is a Delivering Value Series Symposium that is hosted by the Business Healthcare Group. Our next Delivering Value Series Symposium is going to be on August 3rd, and it's going to highlight the new partnership that we have with a data warehouse called Artemis. And then we will have another, we've never had this many Delivering Value Series Symposiums, but there is so much going on currently today. And we will have another, we're hoping to have another Delivering Value Series Symposium on August 16th to talk about the CAA broker consultant requirements that an employer has to meet. And then in addition to that, John Barlament, we're looking to, is an attorney with Reinhardt. He is counsel for the Business Healthcare Group. And John is going to do a Delivering Value Series Symposium for us on the way it appears on August 3rd on the implications of Roe versus Wade for employers. So a great deal coming down the pipe here. So once again, thank you very much. Really do appreciate the time from all of you. Bye now.